Dear Professor Fisher, this is the third edition of the National Neurology Forum, an event dedicated to turning strategies into tangible solutions for brain health. What are your overall impressions of the concept of the forum?
The meeting, which is to discuss various areas in neurology and how to improve the care of patients with those particular disorders, and to bring together a national plan, especially in the stroke area, to improve care, patient education, and patient access is really important. And I think it's going to have a big impact, at least in the stroke area, in improving their ability of patients to get acute care, prevention, and rehabilitation. So I think the concept is really good.
All right. As the past president of the World Stroke Organization, what is your advice concerning global stroke care strategies that Romania could adopt to strengthen the national strategy for combating cardiovascular and cerebrovascular diseases?
That's a big question. So, in seeing some of the slides that were presented today, it's good that there's been a substantial increase in the percentage of patients who are getting acute stroke therapy, both with thrombolysis and thrombectomy. But you have a long way to go. So there's a number of different components that need to be addressed to increase patient awareness. So patient education is an important aspect of improving stroke care so that patients recognize when they're having a stroke and they don't just put it off. They need to get evaluated and treated as quickly as possible. I mean, by and large, acute stroke therapy is time sensitive. So for many patients, the faster they get treated, the better the chances of a good outcome. Another important aspect of patient education is making them aware of stroke risk factors, such as high blood pressure, cholesterol elevation, stopping smoking, treating diabetes, etc. Because by impacting risk factors, you reduce risk. And the risk factors for ischemic and hemorrhagic stroke are very similar to the risk factors for cardiovascular disease like MI. So we have a big overlap because by treating high blood pressure, for example, aggressively, and the target that we now use for patients with a stroke or a heart attack is less than 130/80 most of the time, you can impact both the stroke risk and the heart disease risk. So there's a lot of commonality between neurologists who treat stroke and cardiologists who are treating ischemic heart disease. So those are the two big areas that we focus on at WSO, because the rehab part, which you'll hear more later, that's not so much patient education up front, that's really later. So I think the two big pillars are patient education leading to better reduction of stroke risk, prevention, and then the availability of acute treatment and getting the patients into the medical delivery system so they get evaluated and treated in a timely manner.
Right. The workshops here aim for tangible deliverables. Could you give us a successful example of cross-sector collaboration in stroke prevention?
So that's a great question, and there's a lot of overlap, as I already mentioned, between cardiology and stroke neurology. And we in the stroke field are definitely dependent on having a close collaborative working relationship with cardiologists. So what we've been doing at my hospital in Boston for quite a while now is we have a monthly case conference with interventional cardiologists. And we discuss patients who are being considered for closure of patent foramen ovale, which was the cause of a stroke, or people who need another procedure called left atrial appendage closure because they have atrial fibrillation, and for one reason or another, they're not good candidates for anticoagulation. So we've been doing that for a long time, and we have pretty close thinking now about which patients should have a procedure, what other tests should be done before the closure is done. And then for my own patients, once they're discussed, then I'll contact them and I'll let them know what the recommendation of the meeting was. Another area that we work very closely with cardiologists is we have a substantial percentage of ischemic stroke patients where despite reasonable testing, we still don't know what the cause of the stroke was. And we have a term for that, embolic stroke of undetermined source. And cardiac testing is very important, both leading up to this conclusion that we don't actually know the cause. So we do echocardiograms, both transthoracic and transesophageal, which the cardiologists read. And then we do cardiac monitoring. So they're involved with the reading and interpretation of the cardiac monitors. So we really need their help in trying to find cardiac sources for embolization to the brain. So that's a very good example of how these two disciplines work together. And I hope that the effort here is going to have a similar effect, that there'll be close relationships between the two disciplines.
From your experience, what are the most effective strategies to reduce symptoms to door time?
That's a tough question. So I think the biggest strategy for, there are two big strategies that come to mind. First is we've already talked about patient education so that they don't ignore symptoms. And that needs to happen on a national level, that the media in this country has availability of advertising, hopefully for free, of what stroke symptoms are and what patients should do if they think they're having a stroke. Don't go back to bed because my arm is numb and weak and it's going to go away. You need to access the medical system, and there are various ways that can be done. Don't wait to call your primary care doctor tomorrow. Typically in the U.S., we would advise these patients to call an ambulance and go to the nearest hospital. So patient education about stroke symptoms and signs is very important so that they don't ignore them and they get help. The second part of it is the organization of healthcare delivery services. And I think this is a big part of what this conference and its background is about, is to have a national strategy so that patients who are having an acute ischemic stroke or even an intracerebral hemorrhage where there's no direct treatment yet, that once they're accessing the system, that the system is mobilized to take care of them as quickly and efficiently as possible. And I'll give an example of something that you could probably try to implement, because based on what we've discussed, it hasn't happened much here. Telemedicine is an important new technology. It's not that new, actually. We've been doing it in stroke for quite a while. And so the way this works is that in my hospital, we have a network of smaller hospitals in the area. And if they have a suspected stroke patient that comes to the emergency room, then they'll notify the trainee doctor that's on call with me. And that doctor speaks to the emergency room doctor, and if we decide that a telemedicine consult is appropriate, we're then able to see the patient on our computers. We can talk to the patient, we can examine the patient with the help of the staff in that emergency room, and we can also look at the imaging studies that have been done on this patient. So it allows the relatively small number of stroke specialists to project their expertise into these smaller hospitals, many of which don't even have a neurologist, let alone a stroke specialist. And we're able to pretty quickly make a decision about whether they're an appropriate candidate for a clot-dissolving treatment, thrombolysis, or if they have a large blood vessel that's blocked, and we want to transfer them to the big center for the clot removal procedure we call thrombectomy. So I don't think currently this is being done much in Romania, and I would definitely encourage this meeting and its backing organization to think about organizing telemedicine services, because that's going to really help to expand the patient pool that will get these acute treatments. And even if they're in a small hospital in a remote part of the country, they can have access to experts who can really make appropriate decisions. So there's that, and then there's the whole transportation system about how do you get a patient from one of these outlying hospitals to a big center if they need the thrombectomy procedure. So, you know, there are networks of how that's organized based on the road system here, where things are slow. A helicopter transport is going to be necessary in many cases. So there's a lot to do. I mean, it's apparent that a lot of progress has been made here in the last couple of years, but there's a long way to go. And I know the plan is to really expand patient evaluation and acute treatment. So there's more and more patients who are receiving these treatments, which then lead to much better outcomes.
Thank you, Professor Fisher, and thank you for being here.
Okay, you're welcome.